I would like to introduce Dr. NASA. He is currently affiliated with the Anesthesia and Integrated Critical Unit of a New Cross Hospital at the Royal Wolverhampton of NHS Trust. He has worked in many tertiary care healthcare settings in United Kingdom, UAE, and India. He has a great interest for clinical research with more than 90 publications to his name and written more than 40 chapters in various books of various topics in clinical care medicine. He was awarded Excellence in Healthcare Award in 2023-24 from the UAE government. And Dr. Nasa is also a co-editor of the same book that Professor Brain is, which is a highly popular book of use of rational use of IV fluids in critical ill patients, which has been downloaded, as told, by more than 1 million times. Welcome, Dr. Nasa. So we'll go to the next talk by Dr. Nasa, which is on AI in fluids.
I think Dr. Ray's video is off. Please tell him to put the video.
No, Dr. Nasa is visible. His audio is off.
Video is also not working.
Yeah. Are you able to see my presentation?
Yes,
Yes.
he can hear you, see you, and see the presentation. Sir.
Yes.
Perfect. Thank you, Dr. Tapesh and Vikas, for introducing me and for this kind invitation. I think this is a very important area where artificial intelligence is actually entering, and probably we will see something into this crystal ball, as the topic was suggested to me to look into the crystal ball, how AI can improve fluid management. Let's see, other than my interest in bit of AI, and of course, I've used AI to prepare this talk, so which you will be seeing in subsequent slide. Other than that, I don't have any other conflict of interest. And of course, I'm also co-editor of this wonderful book, which was an initiative both from Professor Melbrain and Dr. Ghosh. And me and Adrian worked together with them to have produced this masterpiece, which is actually being downloaded by nearly more than million times. And if you really want to download, if you have not downloaded it yet, you can use this QR code to download the book. It's freely available by just simple search on Google, or you can use this QR code to download the book. Let's dwell now what is AI and how we can use AI into our fluid management. Is that what I'm going to speak in next 15-18 minutes. So what is the daily challenge? And I think Professor Melbrain has already, it's always a pleasure to hear him again on talking about fluid management. So there is a daily challenge as a clinician, what we should be doing on a bedside, which type of IV fluid, what type of volume we should give while managing patients, or we should stop fluid management in these fluid resuscitation in these patients. And then finally, what type of hemodynamic tool we should use. So this is a daily dilemma which is required at the bedside, either during resuscitation or sometime during maintenance, or overall management of our critically ill patients in intensive care unit. So we always ask to ourselves when to treat hemodynamics, whether we should look at microvascular circulation, we should look at macrovascular circulation, we look at cardiac output, oxygen delivery, or for simple matter, what has been recommended as looking at mean arterial pressure or simply urine output. So this is a daily dilemma, and then followed by how to treat hemodynamics. I think that's another big point which we need to look at, and that what is the main theme of this topic, main theme of this whole day of fluid. What type of fluids, what dose of fluids, or inotropes or vasodilators or vasomodulators we should use for fluids, what type of different tests we should be using, a mini fluid challenge or passive leg raising or a Tendelberg maneuver, or even tidal volume challenge or random expiratory. So there are different type of hemodynamic tools we have, and to integrate this into the patient management by using the right type of or right amount of fluid is a daily thing. And then finally, how we monitor the response of this therapy, looking at again microcirculation, just simply mean arterial pressure or a urine output, or we should actually target something like a microvascular perforation. So this dilemma between macro and micro is ever going, and still we don't have an enough answer. So how we can put a new thing, which is artificial intelligence. So that what I did, asking ChatGPT to start with. How should artificial intelligence be used in case of fluid resuscitation? And the answer which I got was, in a patient with shock, fluid resuscitation is often the first line treatment. However, the decision is should be based on a thorough assessment of patient condition, including the type of shock, hemodynamic status, and underlying cause. And that actually what I think you must have heard so many times since morning today, that this is the way we should be managing fluid resuscitation. But to say it in a simple two words, it's very simply put forward, but very difficult to do that on the bedside. And as I put forward into the last three slides, what we need to do is integrating a lot of information along with hemodynamics and more importantly, sometime even imaging to use this complex information into our daily decision making. Then, I try to see how AI can help me out to make a presentation on AI and IV fluid. So actually, I reached up to this, website where I asked them to prepare a small presentation for me, looking at artificial intelligence and use of IV fluid, and this is what I found.
Today, diving into a revolutionary topic that's set to reshape the way we approach fluid management in healthcare: artificial intelligence. Yep, AI isn't just for tech geeks anymore. It's becoming an essential tool in our medical toolkit. First off, let's talk about the problem. Fluid management is critical in patient care, especially for those in critical conditions or undergoing surgery. Mismanagement can lead to complications like fluid overload, dehydration, and even organ failure. The traditional methods rely heavily on manual monitoring and the clinician's judgment. While effective, these methods can be time-consuming and sometimes prone to error. Enter AI. Artificial intelligence brings a game-changing level of precision and efficiency. Advanced algorithms can now analyze vast amounts of patient data in real time. Imagine having an AI system that continuously monitors vital signs, lab results, and even patient history, providing you with actionable insights right when you need them. One of the standout applications is predictive analytics. AI can predict a patient's fluid needs hours or even days in advance. This proactive approach allows for timely interventions, reducing the risk of complications. We're talking about tailored fluid management plans that adapt in real time to the patient's condition. It's like having an extra set of eyes that never sleep. Now let's get into some specifics. AI-driven systems use machine learning models trained on thousands of patient records. These models can identify patterns and correlations that might be missed by the human eye. For instance, recognizing subtle early signs.
So this is what was a presentation. There was subsequent, talk about how we can use predictive analytics, closed loop systems. So without giving reference, if you have asked AI to make a presentation, it has given you what is all happened in last 3 years. It's very impressive. Of course, it tries to give credit into the images, but unfortunately, there was no, the references where all this is coming up and what sort of summary which we can get from this. So that what probably I will be talking in the next few slides. But yes, this is something is happening at, while we are talking through, and there is a lot of research which is going on. So I will be moving now why and how AI can change what we are doing at the bedside. So a bit of understanding what is AI. So there are now a lot of these fancy terms which are there in the market. We know big data, we know data science, and that is where most of our research is moving forward, integrating of large repositories across the globe into this big data and analyzing pattern and imaging, analyzing these patterns into this big data gives us insight into the large amount of patients which have been collected into these repositories. And I think here I really need one important message where I think most of these big data is still looking into the data which is coming up from Europe or from North America, to an extent in Australia continent. Unfortunately, there is a big amount of population which stays in Asia and Africa, which does not represent in this data. And that could be a big source of bias going forward, because ultimately most of the artificial intelligence is developing also in these areas. Unless we share that data into this so-called data science, the so-called the predictive models will be coming up only from the developed world. And if we do not change our way, the way we share our data, the collect our data, most importantly, how we are putting that into electronic health record, and develop our models looking at these data also coming from Asia and for that matter from India, what will happen is there will be a subconscious bias, and that will lead to the predictive models or the outcome models, or the analytic models which will be coming up from the future AI or machine learning will be very much biased. And that's what we will be seeing in the subsequent few slides also. So simply put forward, what is AI, what is machine learning and a deep learning? So AI is a bigger umbrella which talks about the way a machine react, sense, or adapt to it. While machine learning is a subset of an artificial intelligence where it uses so-called a programming to learn from what is coming from a source data. So it's basically so simply putting it is as like adding a statistical tool to what is there as present as a data, and that through that statistical tool or through that program, the machine tries to learn itself. It tries to improve with time as the data which will be fed to that machine will be getting forward to, so it will continue to evolve. If we put that machine learning into further computation models where the complex neural networks tries to analyze, to bring pattern, to identify these different patterns from that particular data, that brings the deep learning. So it works very similar to our neural networks of the brain, where it not only analyze but also try to learn from the mistake. So from identifying pattern to learning, to followed by learning from the to adapt it in terms of any mistake or try to learn from your mistake, is what as a human we do. And that what deep learning brings down to that subset of machine learning and AI into a much more analytic or complex decision making. And then these are different ways machine learns, either looking at unsupervised learning where it tries to use these program models by continuously to evolve it itself by just unsupervised way, or then we have some sort of supervision through different type of programs where the learning is not just happening but also happening in a supervised fashion, and that is being used at different places like fraud detection, new insights, process optimization, or even to an extent of forecasting. And then followed by a simple behavior mechanism of reinforcement learning, which we have seen as a human behavior, or the way we learn from our mistakes by getting a reward or a punishment. So that sort of reinforcement learning is actually being also added into machine learning these days, and that brings down to a reinforcement learning into the machine learning. Why about ICU? Why we should be using more AI in ICU? We know ICU is a natural habitat. Why so? Because there is a lot of complex data which we deal with on a daily to day-to-day basis. And then we deal with patients who are critically ill, has higher morbidity or mortality. Every day in intensive care unit adds to the cost. And then finally, our decisions which we take on these patient behalf or take in the management of these patients have a lot of consequences which add to the morbidity and mortality. And finally, despite a long amount of research, a large amount of research which has happened in last few decades, we have of course improved the outcome of these patients, but there is still a lot of uncertainty how we diagnose different diseases, so-called these syndromes, which have not a simple way of managing these patients. And we also know now there is no one single approach which fits all. And then finally, the prognosis depends upon many other factors other than simple way of presentation and the way we have treated them. And that led to a lot of uncertainty, and that becomes a role of AI in personalized management of these patients. So why AI? It helps to predict early. So we are able to predict which patients will be having a higher severity of illness, which patient may need readmission into ICU, or may continue to worsen, may have even a mortality. So it helps in the predictive analytic AI, followed by AI can be used in early detection of the diseases by looking at patterns, the way the physiological deterioration is happening. So it helps to predict the diagnosis, but also predict it quite early as compared to the conventional way of identifying or managing these patients. Then help us to make right decisions in terms of treatment approach to these patients. And most importantly, try to integrate this information through our electronic health records, try to extract, analyze, and interpret information which is there in that electronic health record, along with a real-time data which is being captured through different monitors, and integrating all this information into a clinical decision making. So thereby AI is doing a more complex job which we do as a physician on a day-to-day basis, but still there is a lot of cognitive load which we have to face on this such decision making. So then if we put that context of AI into IV fluid management, there have been a lot of things which have happened in last, say 10 years, and that's what I'm going to present with a small amount of evidence summary, which has happened, what has happened in AI in ICU, and what will still need to be done probably in the future. Looking at a closed loop way of fluid administration. So what is this closed loop fluid administration? If you look at on a real-time daily basis, if a patient comes with a shock, you take the history of the patient, you look at the clinical signs of shock, looking at the organ dysfunction, then integrate this information along with the laboratory, with hemodynamic, complex hemodynamic monitoring, along with a bit of imaging, either using ultrasound or an echo, and this all that's integration of information from electronic health record to the real-time hemodynamics. You put that to a provider, which is us, and then we use that decision making to either decide whether patient needs a fluid or needs a vasopressor, or what type of fluid and what amount of fluid need to be given. If we put this provider into a machine which becomes a controller, which integrate this information from different sources, from electronic health record, from the clinical assessment, and also from the complex hemodynamic monitoring, integrating all this information to ultimately guide the clinician whether to give fluid or to what amount of fluid, and that decision will be implemented into a real-time hemodynamic monitoring. So that information is again coming back to the machine in terms of a closed loop. So now, instead of a provider, you are putting a controller into the center of the system, and that is only guiding you or guiding the clinician to make the decision of an appropriate amount or a right amount of IV fluid decision making. So that is something known as a closed loop fluid management in IV, in fluid system or fluid management. So how this has been used, and this review which was published in 2022 tries to put this context how closed loop mechanism can improve fluid administration by looking at enhanced accuracy, because you are giving a precision in the fluid delivery. You are personalizing the fluid delivery by looking at electronic health record and integrating different source of information, and also reducing the cognitive load. So instead of the physician who is making that decision looking at his experience and understanding of this complex information, now this is being done by the machine, which is guiding the clinician whether to decide to give fluid or not to give fluid. And then you are setting up those goals, and that real-time monitoring of the data can be used to deliver goal-directed fluid therapy, which we really aim forward to these days, that we are not using fluid management by looking at just fluid responsiveness, but ultimately looking at whether it is adding to improvement in the outcomes or worsening the harm. So goal-directed fluid therapy putting forward in a real-time context, and that will lead to improve patient safety and reduce the cognitive load, and thereby reduces the risk of fluid overload or so-called even under resuscitation. Then when we integrate this along with electronic health record and looking at various in complex hemodynamic information, that helps on a real-time basis to a clinical decision making. Though we know that all this is looking very complex, and to start with, we will need to do a lot of training of healthcare professionals, and then we also as a healthcare professional have to adapt some sort of these mechanism which can guide us and should have validated these tools. So ultimately it will add to a lot of training for healthcare professional, but in long term, this will make our decision making much more efficient, and more importantly, it will improve to the patient safety. So that what was suggested in this review, that closed loop can improve outcomes probably in the future. So what is the evidence whether closed loop have been used? Yes, there are few studies which are looking into closed loop administration, mainly into the perioperative settings, like this study which was published way back 6 years back in 2018 in European Journal of Anesthesia, where they used a case control study by looking at the historical way of fluid administration in major abdominal surgeries, and replacing that with a closed loop. What they found was net intraoperative fluid balance was actually lower by using a closed loop mechanism by nearly nearly half of what was being administered in the historical cohorts, and also lead to lower amount of major or minor postoperative complication, and also leading to reduced hospital length of stay if the closed group was used instead of the historical or traditional way of fluid administration in these patients. Then there is another study which was recently published, again looking into abdominal surgery patient by Samir Jabbar group. What they found was, again, this is the way the closed loop works, where you use the hemodynamic monitoring or a peripheral or invasive or non-invasive semi-invasive hemodynamic monitoring, putting this into the context of closed loop, and finally that closed loop guide the fluid administration in these patients. And what they found was when closed loop is giving advice, that was in this particular study was actually accepted by only 80% of the time, while in very very small, so they only had 19 patients in this small study, where most of the time these patients were actually having a fluid responsiveness or which was actually measured by pulse pressure variation was less than 13%. So most of these patients remained less than 13%, which means they were not fluid responsive. But despite that, there were a lot of instances where the machine gave the information that a fluid bolus need to be given, and only 80% of the time anesthesiologist agreed with that decision, while the preset was agreement of at least 95%. So finally it did not meet that preset agreement of 95%, and the authors actually gave that closed loop at present cannot replace physician, but only it can help in clinical decision making, where it can reduce for temporarily a cognitive load, and thereby continuously monitor the patients into whether patient needs fluid or not. So yes, there is an way we can look at closed loop system to guide the fluid management, but there is a challenge because most of these closed loop systems are only looking at fluid responsiveness. They are only based on these so-called hemodynamic monitoring, which are looking at fluid responders. And now we know that it's not the fluid responder which decides that we should give fluid, but also look at the risk of harm. So if a patient who is, despite being a fluid responder, also have a leaky capillaries, and we see that giving fluid in these patients will lead to the harm by worsening of fluid accumulation, there we need to be very very careful despite being these patient fluid responder. So that element probably, if integrated into the new future closed loop system, that will give us much more information. And most of these studies have still been validated into a perioperative setting, not been implemented into a critically ill patient, which have much more requirement of these variables, and we don't know whether closed loop will work equally effective into a intensive care unit. But yes, this is something which is artificial intelligence can work on probably in the future. Now, what we should do into the monitoring of the hemodynamics? We know that there is always a confusion what to be monitored, either a macrocirculatory or a microcirculation, and what will be the end targets while giving fluid management in these patients. And this particular study looked at microcirculatory alterations into and integrating of this information through an artificial intelligence by looking at AI and looking image pattern into these complex microcirculatory or capillaries through these electron microscope. What they found was they tried to build up to cohort algorithm based model, a deep learning based model, or a combined model. And what they found was the algorithm based model had a much more higher sensitivity and specificity as compared to the combined model. And the combined model algorithm based model was having a lower sensitivity as compared to the deep learning based model. And when both algorithm based model and a deep learning based model was combined, the thing was much more sensitive and specific. And probably we should use both algorithm, the way we look at these microcirculation, along with deep learning or deep neural network, and using AI can improve understanding of the microcirculatory pattern in the management of these patients. Now, again, there is something we talk about hypotension prediction index. So HPI is a new tool which has come integrating AI into the arterial waveform. So what HPI does is it uses machine learning by looking at the complex data which we are monitoring on a real-time basis of arterial blood pressure. So it tries to predict hypotension earlier than what it will actually happen. So if a patient has having a continuous arterial blood pressure monitoring, so this machine algorithm will try to look at that pattern of mean arterial pressure and tries to predict a hypotension episode at least 15 to 20 minutes earlier than what it will be happening. So it gives us time to react to that so-called hypotension which will be happening after some time. So instead of acting, instead of reacting to hypotension, you will be proactive. You will predict that hypotension and take an appropriate action. But what is been found is whether this tool is good enough and this can be used. So if imagine if you are able to predict that hypotension, but by giving that fluid or starting a vasopressor can improve outcome in these patients. So this has been tested in last few years, and this was a very good editorial which was written by Frederick Mitchell, which is again a big AI enthusiast. And what he found was, yes, we know that hypotension predict index can actually mimic more of a mean arterial pressure waveform it is able to predict hypotension by at least 5 to 15 minutes earlier than when it will actually happen. But targeting therapies by looking at these hypotension, are we up to a mark? No. Unfortunately, the answer is no. We are really not sure whether starting therapy by looking at HPI can improve outcome of these patients. That is still to be proved. And in fact, there are now studies which are saying that, recent prospective studies tries to look at this part that, reducing the intraoperative hypotension can improve outcome. They unfortunately did not show any benefit. So just by looking at mean arterial pressure or preventing hypotension in these patients will not improve the outcome of these patients. So yes, we are able to find these things happening. We are able to predict hypotension, but targeting therapy on these prediction of hypotension is still not been validated. And I think probably in future, this is again one area which will be having much more evidence. And there is a lot of research which is going in, at least in US, by Professor Khanna and colleagues, looking at this HPI tool, which has again been used in perioperative settings primarily to look at prediction of hypotension. Now, again, this has been also used in intensive care unit where we can predict fluid requirement using an AI. So this study, which was way back published in Critical Care, what they used was they tried to not look at the resuscitation part, but looking at the initial resuscitation and then looking at that information into a maintenance fluid requirement. So looking at this complex algorithm where they try to integrate, sorry for this busy slide, but this picture tries to look at a complex information which is used by this artificial intelligence model, where they try to look at complex physiological information along with the history and try to build up this model where they look at small cohort of patient with certain age, sex, and ethnicity by looking from ICU database, and then build up this model, which was further tested into a larger cohort, and try to build up this model to predict fluid requirement in these patients. What they found was the model was nearly 78% accurate, and while they were using the same test and finally validating this model, the accuracy remained nearly 78%. So it was able to predict whether the patient need fluid in sort of a maintenance stage or does not need fluid, and we can safely stop the fluid in these patients. Then, another area where machine learning can help us is to predict hemodynamic instability in the intensive care unit. So we saw that HPI tool, which was still being tested into perioperative setting, but can we have something into our intensive care unit where we usually see more critically ill patients and we have to make these complex decisions? So machine learning has actually looked at validation of these models into hemodynamic instability by, more importantly, predicting these hemodynamic instability in intensive care unit. So this particular study looked at, again, mainly US cohort. What they found was this so-called hemodynamic stability index, which is HSI, performed much better as compared to the traditional way of prediction hypotension, which is shock index or looking at the systolic blood pressure. So HSI was having a higher sensitivity and specificity as compared to the traditional shock index or systolic blood pressure, even up to 24 hours. What was more important was in 95% of these patients, it was able to predict hemodynamic instability by at least 5 hours earlier than what it would be happening. But again, these are just predictive models. We don't know whether correcting hypotension by giving, preemptive IV fluids or vasopressor will ultimately improve outcome. It's still to be validated. And these are, again, more importantly, cohorts which have been taken with a selected population. Mainly in this case was a US cohort. So we need to be very careful looking at the information which is coming from. Maybe the patient which we are dealing in our setting will be having more of a tropical disease, especially in the Indian setting, where the tropical fevers are more common and the reason for hypotension and shock are still predominantly by these tropical fevers. So analyzing that information into or integrating these tools into systems of resource limited setting again will be a challenge because the source information is completely different. Then another model is a machine learning for looking at the volume responsiveness. So previously it was predicting hemodynamic instability. By here, they actually looked at prediction of volume responsiveness, the tools which we use to look for volume responsiveness in patient with oliguric acute kidney injury. What the study was doing was identifying the patients who have an oliguria at the ICU admission. So the first 6 hours, the patient who had a urine output of less than 0.5 ml per kg were identified. Then fluid administration in the next 6 hours was picked up and followed by an 18 hour of looking at fluid responsiveness, whether these patients are able to respond to the fluid challenge or not. So looking at this small cohort of patients who had oliguria, who were given fluid challenges, and then response of that fluid challenge into improvement in urine output or not. By looking at this model, there were there were two models which were there. The traditional cluster model, which has looking at only age, burn, and urea creatinine, and that's the way we look at the acute kidney injury in our patients. We look at mainly the age and then try to calculate the GFR and predict whether these patients will ultimately develop acute kidney injury or not. While machine learning try to integrate a lot of other complex information besides just looking at renal function, by looking at overall physiological parameters which are being captured in these patients and try to integrate this particular into a model. What it was found was this so-called XG boost, the name which was given to this model, performed much better than simple logistic regression model, which try to look at simple tools of assessing of risk factor for acute kidney injury and how these patients will be responding to fluid administration. So machine learning performed better as compared to the simple logistic regression or simple risk factors of acute kidney injury in these patients. And by this complex validated model, what they try to prove was that their model performed nearly 86% with sensitivity as compared to 72% by simple logistic regression. Now, another, usual hemodynamic tools which we use at the bedside is velocity time integral, and that we used as very common tool to look at the cardiac output using an echo and to assess that as fluid responsiveness in these patients. So we know VTI is a very validated tool now, which is being used on a daily basis to identify the etiology of the shock, but also to use this tool as fluid responder or a volume responsiveness by using like passive leg raising or other type of bedside hemodynamic tools. So whether automation can improve these so-called VTI tool or subaerotic VTI tool by artificial intelligence is something again which has been looked up in this study. So what is a bigger challenge is calculating VTI is the inter-observer variability. Whenever we try to put up this probe, so it is so much operator dependent how this window has been created by the operator that will give us whether the VTI which is being calculated is right or wrong. And there automation can help where the color coded and these automated VTI calculation can guide the machine whether the VTI which we are calculating is right or not, and it also helps to improve the VTI which is being calculated by the operator. So what they found by using this particular automated VTI that it works better whether it is being used by expert or trainee. So in the hands of both expert and training, the tool performed much better as compared to when they were not given this tool to calculate VTI and to calculate the fluid responsiveness during this VTI by using the VTI. So automation definitely can help the way we are not only predicting hemodynamic instability, but also can help us to calculate or look at these hemodynamic tools in much more critical way or improve the way we are calculating or utilizing these tools. And finally, this simple machine learning method, which has been used to predict for fluid responsiveness in severe sepsis or septic shock. Again, this study tried to utilize a lot of hemodynamic tools, and what they found was these tools were working better as compared to looking at passive leg raising tools or the other thing. Now, we have learned, I think Professor Manbrain has also talked about fluid accumulation, how we can use that fluid accumulation or how we can early predict this fluid accumulation is really something which is ongoing research. And here again, an AI model has been looked upon by looking at the cumulative fluid and looking into that cumulative fluid to predict the cumulative fluid balance. So just cumulative fluid intake, which is being easily calculated through our intake output chart, which we usually maintain in intensive care unit. By looking at cumulative fluid intake, the model tried to predict the cumulative fluid balance in these patients. We know this ROSE concept, which has been already, you must have heard about this from morning, that there are certain patients which try to go into the flow phase while the other patient would don't go into that phase. So these patients are the patient which ultimately develop fluid accumulation, and partially of this is also being contributed the way we manage these patients by giving fluid resuscitation of these patients or continue to give fluid in these patients rather than de-escalation. So these patients are the one which ultimately develop fluid accumulation. And some of these patients may be actually benefited by doing not just de-escalation, but also de-resuscitation, which is simply removal of excess fluid in these patients. But we don't know how we can predict these patients who needs fluid evacuation or who should be having a de-escalation quite early. So this is where this machine learning model try to estimate cumulative fluid intake into the patient who will ultimately develop a positive cumulative fluid balance, and to predict these patients who will be ultimately in a cumulative fluid balance which will be on a positive side, which is again an independent factor related to the outcome. So by using this CFI, simply put forward can be as the amount of intake which these patients have been received. So by computing these models, it is able to predict which patient will ultimately have a fluid accumulation in these patients. So by looking at this model, what they found was by giving a 48-hour estimation time and then 8-hour prediction window, 50% of the time, this model worked very nicely, where it could predict even a half liter of positive fluid balance in these patients. And if we increase this threshold to 1 liter, where it will show that cumulative fluid balance will be of nearly 1 liter, around 77% of the time, this could predict very accurately that patient will have ultimately a cumulative fluid balance. Again, something which is just on a predictive model, and it performed better as compared to the other tools. Sorry for this slide. So finally, last few things will be on reinforcement learning. We understand that reinforcement learning is some simple way of human behavior which we try to learn by using some sort of reward or incentive. And this can be simply put forward the way we throw up a stick or a ball to a pet, and by using those actions we actually try to reward that ball to a pet or to the dog which tries to run behind that ball. So this reinforcement learning is part of our evolution, and this is a natural behavior, the way we learn both as human and animals. And can we use this reinforcement learning into the machine learning, where it will be awarded or sort of punished for not doing the right thing or doing a right thing? Then reinforcement learning is also being tested into machine learning and has been used or has been tested into intensive care unit also. So this particular model talked about using artificial intelligence of optimal treatment strategies for sepsis in intensive care. So we know that the way we treat the sepsis, way it differs from clinician to clinician, because depending upon the patient which we are dealing on a day-to-day basis, it varies. So this particular data set looked at again US MIC data set, where it tries to pick up a cohort of patient, and through that cohort it tried to create a clinical context of patient with sepsis, and that clinical cohort were further tested by a group of expert physicians who try to give management for these patients, or who try to recommend management for these patients. So looking at that, the complex data set and then the decision making which has been done by the different clinicians, it tries to create a pattern. Unfortunately, in most of the tools, we don't know what is being done in these patterns and how to we can validate, because that's a big black box which is there with the AI, that we don't know what sort of these models are coming with. But in this particular study, that model was actually easily visualized because there was a clinical controlled situation. The context was controlled, the data inputs were controlled, and then the final model which was created by this machine learning was actually being validated into another cohort, and that led to further testing of that cohort. And what they found was AI performed much better as compared to the clinicians who were giving diverse opinion of managing these patients. And when this interpretable model was tested in another cohort, it performed again much better as compared to the original clinicians who were asked to manage these patients. So they could perform, what they found was AI model was actually able to predict better amount of fluid resuscitation, or they could perform less amount of fluid resuscitation in these patients, and the early use of vasopressors as compared to the data, as compared to the information which was coming from the clinicians. Finally, the last thing is this reinforcement learning framework has also been used into ICU hypotension management, and this particular study, which was published in 2022, looked upon that machine learning, the complex model, again into those hypotension prediction. Again, a small cohort of patients were analyzed, and that clinical context was created for a group of experts and what they will be doing to hypertension management of these patients. We know there is a diverse opinion which comes the way clinician manage these patients. While some will recommend early use of vasopressors, while other will tend to give fluid boluses, will wait for the fluid boluses to react, and then what type of hemodynamic tools we are using. So we know these clinical challenges are interpreted by differently in different context and also by the different clinicians. So by integrating that information into this clinical context, what they tried to build up this model again, which was tested into a bigger cohort, they could find that by rewarding something based on a mean arterial pressure or rewarding the machine on the outcomes, which are mortality, they could build up this model, and the model performed nearly as like an experienced clinician, where it can guide the clinician in terms of giving fluid or vasopressor, and it worked nearly with the same efficacy as like a expert clinician in management of these patients, and can predict hypotension very early in these patients. So this review which was done, so far we have seen that these so-called predictive models have been tested into smaller subset of patients, but ultimately the question remains is whether these models are now matured enough to be used on the bedside. And this nice, systematic review which was done by Paul Elber and group, where they try to look at whether reinforcement learning can improve outcome of critically ill patient. Have we reached up to the stage? Unfortunately, the authors found there are no studies to demonstrate that at present using these so-called reinforcement-based technologies can improve patient outcomes. So I believe they are still in a testing stage. Probably in future we will have more of these tools which can be used on the bedside. So the people who really want to take away any home message, whether we have reached to a stage where we can use these tools at bedside, no. Answer is simply no, because still it's more in an evolution stage where there are a lot of gaps which we need to fill up. And more of that is also looking at the data which has been used in these so-called models. So what is future? There will be a lot of evolving technologies which are coming up, which will be looking at predictive analytics, natural language processing into the documentation. And I think which will be a very important thing, because the way we prepare our discharge summaries of intensive care patients or patients with complex disorders are really bad. And I think their AI can be very helpful. Again, wearable monitors will try to use this information not just in intensive care unit, but pre-intensive care and post-intensive care, and try to bring down that information into an actionable, AI, which will something which we need to see. And then there are potential developments which can improve our decision making, especially the adaptive and actionable AI, which is probably the future, which will move only not the current predictive AI, but also to an adaptive AI. And finally, we should look at the integrated AI-driven ICU management system, which can help to improve fluid management in our patient. And that I really look forward to. Probably in future, the decision of fluid management is not only left to a poor trainee who is integrating all this information at the night, but this information should come from a machine, whether to give fluid or not to give fluid, whether to start vasopressor and when to start vasopressor. So all this, if it comes, that will on the bedside can improve the outcome of our patients, and ultimately reduce the error which we come from, the way we decide the decisions, and left depending upon the expertise of the clinician, and sometimes the amount of tools which we are using in using these tools at the bedside. So to conclude, it's a very, very exciting field. We all know, we are seeing that and we are hearing that on a daily basis. There are a lot of daily things. Daily there is some new software which is coming up, and we see there is AI has replacing this, AI is going to replace that. But I believe at present that is much more of a myth, that AI is going to replace clinicians. But what will be more important is the people who are using AI probably will replace the people who are not using AI. That's what I really believe, and that where we should be looking in the future. So getting closer to the promise of personalized medicine, and there something I think AI can help us. Not quite ready for the bedside, but keep watching this space. That was the whole message for the talk today. Thank you. If you want this presentation, I'm happy to share. You can write a mail to me. I will be happy to share this presentation. Thank you.
Thank you, Dr. Nasa. Thank you. It's a wonderful lecture. First of all, I will really trying to congratulate you, because first of all, you describe what is AI, what is machine learning, and what is deep learning. Many of the time, all the talks of AI are there, but the clarity between those things are lacking. That will definitely help the the listeners who are listening to this lecture. So I have one question from Dr. Thakur that regarding the wearable monitors, are they available worldwide? And is there any wearable monitors regarding
Hello. Uh,
hemodynamic information and integrating that information into prediction of the tool. So these wearable monitors are being used into research at present. Are they going to change the way we managing our patient? Yes, likely yes, because there is a big gap while remote monitoring these patients is a big gap which we learned during COVID-19 pandemic, and probably that gap which was left over before these patients enter into the intensive care unit, or they are the way these patients are being monitored after surgeries or after discharge from ITU is something a big gap, because as soon as they are out of the ITU, they are left over with a more of a intermittent monitoring, and most of the events happen during that intermittent monitoring. So wearable monitors are into testing stage, and there is a lot of data which is being available and which will be available very soon about these wearable monitors.
Yes, thank you, Dr. Nasa. There is another questions regarding uh, is there machine learning will be helpful in phenotyping?
Yeah, I think this is a very good question, and I really believe the personalized medicine is something which is still being left to the person who is treating them. So the way, and this is something the need of the hour, that we believe that syndromic way of approaching major diseases, whether it's ARDS or sepsis, is not working, and most of the trials are producing negative result is only because we treat these so-called big complex syndrome as one size fit all. So personalizing, phenotyping or subphenotyping these diseases using machine learning is something which is happening, and there are few studies, at least in ARDS, which have found using these machine learnings and develop using the biomarkers, you could produce subphenotyping, and the outcomes behave, or the so-called intervention behave differently when you do subphenotyping in these patients.
Thank you, Dr. Nasa. So I have one question, Dr. Nasa, is that so whatever we have the fluid models available, most of them are in the set of perioperative setting. And it will not be a wise decision to use them blindly in a critical care setting, because the fluid requirement in a critical care patient maybe have different factors starting from the permeability, whether the patient is sepsis or not, the comorbidities the patient have. So do you think that is the reason we have, because the data regarding this are not great enough so that we can have a predictive model for that with the AI generated model, that is why we don't have any closed loop monitor, or at least there is one study, but most of the time it is lacking the ICU environment.
Actually, it's a good thing, and it's a good argument that we should use or not. But before that, I think why we are testing mainly into perioperative phase, because that's a much more controlled population. The data which is coming up from that population is in a controlled. The variables which are being captured are in a controlled setting as compared to the intensive care unit, where there are a lot of variables which affect the patient. And that's the reason whenever you see a new hemodynamic tool comes into clinical practice, they always are being tested first into perioperative setting, because the population is much more controlled, and they are anyway being monitored through different type of invasive devices. So it's easy to validate first these tools into perioperative settings, and the tools which become successful into the perioperative settings are then usually comes to the intensive care unit. So as we saw that most of the studies are being done at present into perioperative settings, just because the population is controlled, we can analyze that result. The model which will be coming from that result will be something which we can understand, and that model, if it needs a refinement, well, it will be going for that refinement, and ultimately will be validated into intensive care unit. At present, the answer is whether these models are matured enough to be tested in intensive care unit. We have seen that results are mixed. Some of these tools have worked while others have failed. Most importantly, most of these tools are being tested from a data which is coming from the West. So we need to be very careful while putting this information into a clinical setting of India, or for that matter into any other resource limited setting.
So another thing, what I when I search regarding this topic or listening to a talk, I find out that most of the data we have regarding fluid management and AI, they are in bit and pieces. So AI in a particular aspect has been developed, particularly some machine learning has been developed. But to integrate all those AI and to have a computed by the computer to have a definitive pathway to lead to decision making or a deep learning part of the AI is probably missing in the ICU. Is that correct, or is there any other aspect to that?
I think it's an area of ongoing research. There are few small pilot studies which have been done, as I try to show, where they use reinforcement learning and deep learning tools into not just fluid management, because that's a bigger area. But first thing is to look at the hemodynamic tools, whether to assess the hemodynamic tool or to assess the hemodynamic instability. So those tools are being tested in a small pilot cohort. So they are into testing stage, and the results are again mixed. Some of them have able to predict that hemodynamic instability, or some of the other tools have failed. But the important thing is those models are still in a very testing stage, and most importantly have been tested in a smaller population. And then putting this into a bigger context of a fluid management is an area of ongoing research. Unfortunately, the simple answer to your question is there are still not enough information to put up deep learning, or so-called, the way these so-called complex neural networks tries to look at the error and to use that error to improve themselves. So those are the still areas of ongoing research. I don't find any particular study where they looked at deep learning networks into the fluid management.
Yes. Thank you. Any other question from the audience? If not, one question lastly, Dr. NASA. So, do you really think in the future or in coming years it will be possible to give a fluid purely on the basis of direction by AI or machine, or it is going to possible, or it's always going to supplement your decision making? Or any
Because the
parameters can
simple
use?
answer is I'm very optimistic guy. So I really believe that we should adopt technology, but always question technology, whether we understand it enough. So I believe that there will be tools which will be guiding us. So if we look at 10 years back, we were not using hemodynamic that often, but now hemodynamic is something we cannot even think of not using in the fluid management. So the same way, probably in artificial intelligence, these tools will guide us, but the simple, way of thinking that they will replace it, I don't think so. They are only going to help us. They will guide us in precision decision making, and that is something we should look forward to.
Yes, absolutely. I also believe that maybe every time you give fluid or any drug, that the machine learning algorithm will give you some alert whether you can give it, or these are the things you should look at. That may be the reason. But completely replacing, mainly in ICU environment, may not be possible. Maybe in a much more controlled environment, it may be possible to give the fluid where the number of confounding factors are less.
Yeah.
Any other questions by the audience? So, if there are no other questions, thank you, Dr. Nasa, for your excellent talk, and it's really well researched and well presented. And thank you for all the discussion.